All right, guys. So, ventilator capnography BiPAP. This is Kelly back here. She's an RT from Toledo, correct?
Yes.
Okay. So she's going to be helping us out. This is going to be a lot of hands-on this month. We're going to go through a quick PowerPoint, and then we're going to be putting our hands on the vents because it seems like everybody has questions about how do I make it stop beeping, how do I do this mode, how do I do that. And then we're going to go over the BiPAP protocol. We have masks here, so if anybody is willing to put a mask on, see how it feels, so that way when we get our patients that we can kind of teach them on how it's going to feel, how it's going to sound, things like that. So it's going to be a lot of hands-on wins. So you're going to have to wash your hands from the donuts.
Great. Hands-on wins. I don't know if I'm a hands-on wins.
Our objectives: identify and discuss common vent terminology. There is a lot that goes behind the vents and all these different meanings. We're going to go over a lot of that. Explain the principles of mechanical ventilation, capnography, and BiPAP. Demonstrate the understanding of BiPAP setup, troubleshooting, and patient teaching. Review the new Sylvania Fire and EMS BiPAP protocol. Talk about some common respiratory diseases. Talk about SALAD technique. And then we're going to also review our RSI protocol. This is RSI month, so everybody's going to get a chance to go over that in the skills station. Vent terminology for firefighters. So these are some different basic modes of ventilation. This is invasive ventilation if we have somebody that's intubated. Assist control. This mode ensures the patient receives a controlled or assisted breath. Breath is triggered by the patient's own effort, but is delivered according to either a set volume or pressure. Synchronized intermittent mandatory ventilation, SIMV, delivers mandatory controlled breaths at a set rate. Any spontaneous breath the patient takes between the mandatory ones can be supported with pressure or demand flow. What does that mean for us? Not a whole lot. Here, our vents are set up in assist control. So if we intubate somebody, we're going to put them on assist control. That's under our adult setting. Other than that, don't read too much into it because that's a whole lot of stuff that Kelly would use in the hospital as far as pressure modes, volume modes, things that don't really concern us in our short period of transport times. CPAP, continuous positive airway pressure. We should all know what CPAP is by now. BiPAP or bi-level, those two words are used interchangeably. So this mode provides two different pressures. You have an inspiratory pressure, which we refer to as the IPAP, and an expiratory pressure, the EPAP. So think of it as you get a higher pressure when you take a breath in, and then when the patient exhales, there's still pressure there, maintaining PEEP, but it's at a much lower pressure. So instead of just that one constant pressure, we get two pressures. Abbreviations: BPM, we all know is breaths per minute. VT is tidal volume. That's how many mLs that we're taking in for each breath. Our PIP, peak inspiratory pressure, that's the highest pressure reached upon inspiration. These vents are smart enough they measure pressures. So when we start getting a high PIP alarm, that's because the pressure in their chest is too high for what we have set. PEEP, positive end expiratory pressure. Pressure that remains in the airway at the end of exhalation, used to keep the small airways in the alveoli from collapsing. FiO2, this is the fraction of inspired oxygen. So we currently are breathing an FiO2 of 21%. We have 21% oxygen. Turn it up to 100, that's pretty simple, 100% oxygen. The I time, the duration of the inspiratory phase of the breath. E time, the expiratory phase. So anybody that's ever done like box breathing, you take your 4 seconds in, that's your I time. You exhale for 4 seconds, that's your E time. Your IE ratio, the ratio of the inspiratory time to the expiratory time. And then you've got your IPAP, inspiratory positive airway pressure, and then your EPAP, expiratory positive airway pressure. So remember, expiratory, breathe out, inspiratory, breathe in.
So to add on to what he was just saying, the I to E ratio, you're going to see that on your ventilators, and it's going to look at a fraction of 1 to 3. So that's the general range for the inspiratory is 1 second. It takes you 1 second to breathe in. Usually when it's expiratory, it's double that. So 1 to 2, 1 to 3 is the general range that you normally see ventilators set at for most people. The IPAP, correlate that with tidal volume, okay? So when we start talking about BiPAP here in a few minutes, the IPAP is going to give you your tidal volume. The EPAP is going to give you your peak. So if you guys can remember that, that's going to help you out a lot.
Also, who's heard of the BiPAP settings of like when we go into the hospital and say, okay, let's put them on BiPAP 12/6. Anybody ever heard that before? Kelly, I know you have. So those settings, those numbers, is our IPAP over our EPAP. So for example, our protocol starts at 10/5. So they're going to have an inspiratory pressure of 10, expiratory pressure of 5. So their PEEP is going to be 5, essentially. BiPAP, non-invasive positive pressure mode, used to support breathing and decrease overall work of breathing. The advantages of BiPAP over CPAP, it's more comfortable. That's mostly the reason why hospitals use it. It's more comfortable. You still get your PEEP, you still get your pressures on the breath in. It's less claustrophobia, better for certain conditions, avoids intubation. There's been numerous times in my career that I've seen that we've been able to avoid somebody getting intubated because got them on BiPAP soon and early, and they were actually able to turn them around before intubation. How it differs: CPAP, constant. BiPAP offers that higher pressure during inspiration and then that lower pressure. So, like I said just a minute ago, IPAP over EPAP is where our BiPAP settings come from. So 12/6. I just got a little short video here. We'll kind of breeze through it here. It just explains a little further in depth, the differences between the BiPAP and the EPAP, or the CPAP. So.
Does anyone in here wear CPAP at night? Anything like that? Ever worn a CPAP?
I'm supposed to, but
so you guys know what it feels like, right? So that constant pressure coming at you, the BiPAP lowers that pressure so that way it's easier for you to exhale and be able to get rid of some of that built up carbon dioxide in your blood. It's a lot more comfortable instead of breathing against that constant pressure. So that's why it's going to make it a lot more comfortable for a patient.
Is your CPAP? Is it a full mask or is it just your nose? Is it?
I use the full mask too, and I couldn't do it here.
So a lot of times, and Kelly, correct me if I'm wrong here, and you can feel free to chime in at any point in time. They're switching a lot of like sleep apnea CPAPs to just the nose, so that way it's A, more comfortable, and B, if something happens and you start getting too much pressure, you can actually just open your mouth and you're gonna get a little bit.
But you can't talk when you have it just in your nose. I tried that shit. Just blowing air out.
Yep.
Now there's some talking.
Well, that's okay for some folks.
Yeah.
Hey, who you're sleeping next to.
So. Now, keep in mind, this video is a little more like ICU.
Christ's sakes. Recording. You can't cuss when you're recording.
Alright guys, welcome back to another lesson. In today's lesson, we're going to be taking a look at the differences here between CPAP and BiPAP, topics related to respiratory therapy. And so I really encourage you guys to head on over there and check out his channel. Alright, so let's go ahead and get into our lesson here and start off with an introduction here. Now essentially CPAP and BiPAP are two different versions of something that we call non-invasive ventilation. You can also hear this go by another name of non-invasive positive pressure ventilation, or NPPV, but essentially what this is this is a less invasive way for us to be able to provide support to our patients who really need help breathing. And ultimately we do this without the need for endotracheal tube intubation. When we have the need for an endotracheal tube, this is then what we call invasive ventilation, and it's actually going to be something that I'm going to talk about in a future lesson here. But the important thing to know here is that we're going to be using this in patients who have either respiratory insufficiency or ultimately respiratory failure. And so if we take a look at our respiratory failure, there's actually two different types that we can see. The first one is our type 1, or what we call hypoxemic. And this one here is going to be a failure of oxygen exchange, so essentially a failure to oxygenate. And this one is really defined as having a PaO2 of less than 60. And the other type of respiratory failure that our patients can have is what we call type 2 or hypercapnic respiratory failure. And for this one, we can think of it as a failure to exchange or remove carbon dioxide, thus a failure to ventilate. And ultimately, this is going to be defined as having a PaCO2 greater than 45. Now, important here is we can have overlap and combination of both of these types. Now, if we look at the different treatment options that are available for these respiratory failures, if we look at our hypoxemic respiratory failure, there's two different things that we can essentially do. First, we can increase their FiO2, or the oxygen that they're getting delivered. And this would be essentially increasing that oxygen supply that we're providing to our patients. And we are going to see this FiO2 in a fraction form, with 100% being represented as 1.0, and room air, which we know is 21% oxygen, being 0.21. Now, the other thing we can do to help with hypoxemic respiratory failure is we can increase our patient's mean airway pressure, and we would use this to open back up and recruit any collapsed alveoli. Now, our treatment option for our hypercapnic respiratory failure is actually pretty simple, and essentially we need to increase our patient's minute ventilation. Now, the way that we can do this is through two different things. We can either increase their respiratory rate, or we can increase their tidal volume. Now, given that we should be setting a tidal volume based on our patient's ideal body weight, this really kind of leaves us one option of adjusting our patient's respiratory rate if we want to impact their minute ventilation. Now, the big takeaway that I want you to get from this is we really need to reverse the underlying process if we truly want to fix the problem for our patients. The non-invasive ventilation is really only support to fix the problems that are associated with this underlying disorder. All right, hopefully that makes sense for you guys. So let's go ahead and move on from here. So let's get in here and talk about the two different types of non-invasive ventilation that we have, CPAP and BiPAP. Now, before we get started, let's go ahead and test your guys' knowledge here. In the comments down below, let me know what makes CPAP different from BiPAP. By the end of this lesson, you should have a much better idea of these differences, but if not, I will be on here responding to your guys' comments to try and answer them or really explain in more detail if needed. All right, so like I said, there's really primarily two different types of non-invasive ventilation. The first one is what we call continuous positive airway pressure, or CPAP, and the other is what we call bilevel positive airway pressure, or BiPAP. All right, so let's start here talking about CPAP. So this is actually something that's similar to positive end expiratory pressure, or PEEP, that I am going to talk about in the future lesson when we talk about ventilators. But essentially, CPAP is beneficial for patients with the hypoxemic respiratory failure. So CPAP is a good option in helping our patients who have congestive heart failure. And the reason for this is because CPAP actually increases our patient's intrathoracic pressure, and this can ultimately reduce their preload. So this can bring the heart back from that far end of the Frank-Starling curve and really ultimately improve their cardiac output. And in addition to that, the pressure inside the alveoli can really help to push that fluid out, hence the congestion, really opening them up to gas exchange. And really the biggest benefit of CPAP is the ability to reopen or recruit and ultimately keep open collapsed alveoli and kind of splint them open. Doing this is going to help decrease our patient's work of breathing and ultimately providing more alveoli to be available for gas exchange. All right, CPAP is also another thing that has a lot of benefit in patients with obstructive sleep apnea to really help keep open their airways. And ultimately, CPAP can help to increase our patient's functional residual capacity, which is really that reserve that a patient has for their own respiratory function. All right, so if we actually talk about the settings that we have available for CPAP, there's really only one setting of pressure, and this pressure we're going to have delivered throughout inspiration and expiration for our patients. Now, this pressure is usually going to be in the range of 5 to 25 or 30 centimeters of water, but we probably really shouldn't go above 20 when we're dealing with acutely ill patients. Kind of our reasoning for this is if we increase that pressure, we're going to increase that intrathoracic pressure too much, and this can ultimately lead to hemodynamic instability, as well as the higher these pressures that we have, the higher risk we run for insufflating a patient's stomach, and this can really increase their risk for emesis and aspiration. All right, so let's go ahead and move on and talk about BiPAP. You may also hear this one referred to as bilevel or BPAP. These are all the same thing essentially. And BiPAP is going to be useful for our patients that have that hypercapnic respiratory failure or a combination of hypoxemic and hypercapnic failure. So this is going to be a good option for patients with COPD as well as our patients with heart failure. We're going to see some of the same benefits that we were just talking about with CPAP with our heart failure patients, as well as COPD here. This is patients who are having trouble with ventilation, and that's one of our big benefits to BiPAP. Now, BiPAP is a really good option to help and prevent intubation, or if we need to wean really difficult patients from the invasive ventilation, BiPAP has really been shown to decrease mortality in these patients. So now, essentially, as you probably figured out from the name, bilevel means that we have two pressures. We're going to have our inspiratory positive airway pressure, something that we call IPAP, and then we have our expiratory positive airway pressure, or our EPAP. So our inspiratory positive airway pressure is a pressure that this is going to provide to patients when it senses inspiration. And you can really think of this as support for the patient taking a breath, thus it's going to help with that ventilation. The settings range that we usually see for our IPAP is just like we had talked about with CPAP, usually from 5 to 25 or 30. Now for our expiratory positive airway pressure, we can really think of this one as being like our CPAP. Essentially, this is a lower pressure that's going to be applied throughout expiration. And again, this is going to help to provide support and really keep those alveoli open and support oxygenation in our patients. Now, we can set our patient's EPAP to 0 if oxygenation is not the problem. The human body naturally has a physiologic PEEP that's about 2 to 3 centimeters of water. And this is a key difference between non-invasive and invasive ventilation is in intubated patients, this is not an option. That's something, again, we'll talk about in a future lesson. Ultimately, though, we can go from either 0 or any number up to but less than our IPAP because, again, we want to have that difference in those pressures. Now, ultimately, the difference between these two pressures, our IPAP and our EPAP, is what's going to give us what we call our pressure support. And this pressure support is what's going to help to determine what our patient's tidal volume is. The bigger the difference that we have, the bigger the tidal volume that our patients are going to receive. And the more tidal volume that we get means we're going to have more ventilation and thus CO2 clearance. Now, there are some machines out there that do allow you to set a respiratory rate and an inspiratory time on them. And essentially, this respiratory rate is really just the timing between when the machine is going to automatically switch from our IPAP to our EPAP. But in reality, most of our patients that are on this are already going to be pretty tachypnic and really are not going to need this setting. Now, there actually is a newer version of these machines. It's something that we call AVAPS, and that stands for Average Volume Assured Pressure Support. And essentially what this machine is going to do is it's going to automatically adjust the pressure support breaths, trying to achieve a target tidal volume that we set. And the way that it does this is it uses a feedback loop to either increase or decrease the pressure in order to keep that tidal volume at our goal level. So this is something you may come across.
Player's mud. I say that's a lot of the basic things that we already discussed, but somebody else's voice, it might sound a little more interesting than me. So, all right. Has anybody ever done an inline breathing treatment? We can do them with our CPAP. So, if you look, they have a HEPA filter in there. You can put that on the end of your expiratory side if you're worried about them having a bunch of cooties and you don't want to get up. So the way they have it built, mask, you put your nebulizer in there just like we normally would. You can throw an end tidal in, and then you just have the rest of it hooked up just as normal. You do have to have that secondary oxygen source for the nebulizer, just like a regular breathing treatment. So that goes in, have your oxygen there, gives your breathing treatment while you're giving them BiPAP. Vent alarms. Who's had a vent alarm with this? Everybody?
Everybody shared.
So these are the common ones that we're going to see. High pressure, so the airway pressure is higher than the set limit, usually due to increased resistance or decreased compliance. Low pressure, the vent is sensing less pressure than expected, so there could be a leak in the actual circuit itself. It could be disconnected somewhere. It could have come connected or unconnected from the patient. And then our apnea alarm. They stop breathing. So the vent will pick up on that. There's a certain time frame that 6-8 seconds. If the patient does not trigger a breath on their own, it will begin to alarm that, hey, your patient's not breathing. You need to check him. So the most common one that we're going to see and that we've seen so far is the high pressure. This is just me up here talking. Where do we see our most common high pressure alarms at? Think about situations where we've used the vent in the actual ventilator mode. CPR. Why is that?
Because we're pushing on the
Creating
chest.
high pressure.
Creating high pressure. We're pushing on the chest. Once again, this is just me. I've noticed since I've been here that we like to use these vents during CPR. In my almost 20 years in hospital, out of hospital, the flight, wherever, as soon as somebody goes into cardiac arrest, Kelly, what's the first thing we do? We pop the vent off.
Bag mask only.
Old school BVM, whether that's through a tube, an eye gel, or just BVM with a mask. And I've seen it before, Zach. I think we were on that one code kind of down. I don't know if it was your district or ours, but it just kept beeping and alarming.
So we popped it off.
Yeah, and honestly, that's what's going to happen every time. No matter how much you change your PIP settings, your peak inspiratory pressures, because we're pushing on the chest, it's going to go up and it's going to go off. And it seems like every time that we do that, people start focusing like, why is this thing beeping? Why is it? Well, I don't know what to do. And then here's our patient over here that we may have gotten ROSC on, but because everybody's super focused on the vent and it's alarming and it's going off, we don't know, like, oh, are we due for another epi? Oh, they're in VFib, we can shock. So my opinion is once we get ROSC, then we can put them on the vent. But until then, old school BVM. So my opinion on it.
So in front of you guys on your tables, there's some alarms that were brought up. Some of these are the common alarms that a lot of people were seeing. So we went through, kind of made a new picture diagram, kind of walk you through how to resolve them. And then on another side is an algorithm to help you go step by step with the causes that is usually causing that alarm. So feel free to pass these down. You guys can look at them. If you guys have any input, these are still in the working phase. We can get these adjusted. If you guys have any more recommendations.
What about peep leak?
Peep leak?
Yeah.
So that's when you're going to follow your doper's mnemonic. You're going to start at the tubing, make sure all the tubing's hooked up correctly, going all the way back to the patient, making sure that there's no leaks anywhere. If they're intubated, checking that cuff, making sure that cuff is properly inflated, verifying lung sounds, everything.
You say peak or
Peep leak.
Peep leak. I got you.
That's the one I've seen the most common.
So yeah, and that's going to be
Losing pressure somewhere.
they're losing pressure somewhere.
All right.
So then that's just basically just a
A leak somewhere.
quick troubleshooting guide. Like, am I loose on the circuit somewhere? Is the cuff, like, if we're intubated, did the cuff get torn? Was it a traumatic intubation and we snagged a tooth on the way in and now we ripped the cuff? So it's just kind of going through and kind of troubleshooting.
With chest rebound. Would chest rebound while it's trying to ventilate cause that? Because it would seem
Say that one more.
like most of the time I've seen I've seen these. It's only been during minus the CPAP nightmare, but most of the time it's only ever been during CPR that we have like the crazy. So is it compression?
Yeah. Basically, because you got to think, like they said on the video, we naturally have a PEEP of 1 to 3. That's just natural. So there is pressure changes in the chest, and then once you start pumping on them, now you're up and down, and that's
Why
where.
are we putting these on then?
Hmm?
Why are we putting these on during cardiac arrest then?
Are we changing? We might be changing.
I just looked through the protocols and doesn't even say anything about.
It's easier to ventilate a
Without.
patient without the vent. Because the vent.
That was
Psychic
something that was
stuff.
new to me when I started here, because, like I said, all the codes that I've ever worked in hospital, out of hospital.
Well, I just looked up the cardiac arrest protocol and it doesn't even mention.
Mm-hmm. And some of you guys, Lieutenant, I mean, that was always with the auto vent. There wasn't really anything to yell at you, squeal. I mean, it made some funny noises, but and it was always used as an extra hand, basically, correct? That's one less person that we need to have at the head, squeezing a bag, giving a breath. It was consistent, and that was my assumption as to why we always did that. Even though now we have something a little smarter technology, now it says, hey, something's not right, so like I said, that's just my opinion. That's not the opinion of the department. Obviously listen to your officers.
Extra set of hands plus it helped curb that overventilation.
Mm-hmm. Yes, sir.
Is there any kind of statistics on how our ROSC and CPR efforts were when Lucas County was still here, and now Lucas County's gone away and we got fancier events? And can we compare how good our arrests are being managed?
I know we are able to pull information as far as ROSCs, rates, and all that kind of stuff. I don't know about the Lucas County end.
We don't have access to that data right now, and we don't have the same criteria that we had back then.
Gotcha.
So rescue pods, we don't use those. We were using those during Lucas County days.
Okay.
Obviously, auto vents, we were using those compared to these. We're able to alter these a little bit more. So
This is
not really
anecdotal,
apples.
100% anecdotal, because it feels like we're getting more ROSC. Now, I don't know if they're walking out of the hospital more or not, but it does feel like we're transporting with a pulse more often than not than we were when we were in Lucas County. It just does. I mean, I don't know if it's the rescue pod or the gigantic tree of stuff that we had to have, or the 50 different studies we're involved in, but it just feels like with these protocols, we're getting people back and we're going to the hospital with somebody with a pulse. I don't know if the data is showing that, but like my crew, I can't remember the last time we left somebody. So.
Speaking with Jeremy from the last class, he got an update from Dr. Brookins, and rescue pods, we're going to start carrying those again. We're going to go to the 10s instead of the 16s that we finished with, because the data doesn't support the 16s, the higher pressure. We were getting better ROS rates through Lucas County when we had the 10s. So that is currently in the works now.
Any other questions? Capnography.
Rescue the pods, going to the 10s instead of the 16s. Pressure difference.
That's apparently in the works. Brookins is a big fan of those. So, capnography. Why is in-title monitoring important? Assessment of ventilation respiratory status reflects how well CO2 is being eliminated. There's plenty of variables. The biggest one we should use it for, confirmation of airway device placement. Even with the old color metric changing, yellow yes, purple poor, those can sometimes be unreliable. In-title is considered the gold standard. And we also need to, when we intubate those patients, we also need to keep an eye on that. If you lose your waveform, it's possible we lost the tube. And then monitoring of CPR and circulatory status, cardiac arrest, we use that to check and see if we got ROSC. You get that spike, there's your ROSC. These are typical waveforms. This is your normal. Here's one. You can see that we have kind of low, 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 then we get that sudden spike, indicates ROSC. We can even trend. You can see this one here. We are what appears to be a normal, we'll call it normal, and now we're trending down. That could be reflective of, you know, their